Very, very good evening to all of you from AIG Hospitals. I am Dr. Rajiv Menon, a cardiologist in AIG Hospitals. And today with me on the panel, to my left I have Dr. Swaroop. To my right I have Dr. Anuj and Dr. Prasad Reddy, who will be sharing their vast experience. Today we'll be having the 14th interventional webinar in our series from AIG Hospitals, and probably it is the most important webinar which we are going to have in this entire series, basically because we have one of the most distinguished guest faculty with us. We have Dr. Ferenc from University Heart Center in Freiburg, Germany. I am sure many of the people listening to this webinar would not need introduction of such a distinguished faculty. He's been one of the founder members of the European Bifurcation Club. He's had a long association with India where he has been repeatedly coming to Proctor, not only in complex PCI but also in the TAVR cases. And it was extremely kind of him to readily accept our invitation to be part of this particular webinar. As all of you know, he's been one of the primary authors of the EBC main trial, and I think most of you will agree with me if I mention that this is one of the most path-breaking and landmark trials in bifurcation which we have had in the last couple of years. And listening to him, I am sure, is going to make a huge difference in the way we practice interventional cardiology and the way we practice bifurcation. So without further delay, I think I'll hand over the podium to our distinguished guest faculty, and welcome sir to AIG Hospitals, and request you to kindly go ahead with your presentation. For some reason, I think Dr. Ferenc has just stepped out. So what we'll do is we'll probably just, Dr. Ferenc, thank you very much for joining us. We just had a brief introduction. I'm not sure if you could listen to that, and we are indeed privileged to have you with us. In all the webinars which we have had, probably this is the most important, basically because we are having someone like you as the guest faculty in this particular webinar. So we would hand over the podium to you and request you to go ahead with your presentation and tell us about what are the most important learnings from the EBC main trial. Over to you, sir.
Yeah, dear colleagues, welcome from Germany, and it's a great pleasure for me to be in contact with you. So due to pandemic situation, it's really, for me at least, very difficult for traveling. So I will just start with the presentation. Just a second. And we are really very glad to have now the option to get more current data regarding how to manage the distal left lung bifurcation lesions. And our colleague from EBC Maine, David Hindley-Smith, presented this data during last Europe PCI meeting. And I will just go to this presentation. There are two presentations, that's one. So now, just a second. So I can open now this new slide set. Okay, and I have to share the screen just a second. So I think it should be, now you can see the slides?
Yeah, very well, sir. We are able to see
Perfect.
quite clear.
So, dear colleagues, so according to the European Revascularization Guidelines from 2018, so according to the left main stenosis, we should know, and we should always consider this information for our decision making, to make the right decision. So we should also take into account that syntax score is here important, and if you have, let's say, isolated this left main stenosis, and finally you will be in the syntax score range between below 22, so you have a green light to go with PCI. It's a 1A option. If you have intermediate syntax score, so cabbage is green, PCI is just yellow, so it should be discussed definitely in the heart team. And if you have distal left main stenosis or left main stenosis in setting of the very complex coronary anatomy, and your syntax score is quite high, higher than 32, then practically the better option, first option, will be cabbage. Only if there is a problem with surgery, if surgery refuse to operate the patient, then you could go then with PCI. And you will find this the left main stenosis in the setting of PCI in something between 3 to 5% of cases, bifurcation in around, bifurcation lesion PCI in around 20%. Now there are very different anatomies, as you can see here. Look, just this huge bifurcation angle. In this case, it was planned collot, but you can see it was provisional collot, and you could just manage this very complex anatomy only with one stent, kissing with huge diagonal branch and kissing with circ, check it by OCT, very nice result. And if you have such subtotal distal left main stenosis, practically including trifurcation, so definitely you need here to stent management, and you should always try to keep the intermediate branch open. And what is really the main problem in distal left main? As we know, we have in majority of cases really calcified distal left main lesions. So in many cases, if you have to prepare the lesion with rotablation or orbital atherectomy, whatever, or shockwave balloon, and especially if you have patients with severe reduction of the LV function, you should consider to perform such PCIs under impeller protection, like in this case, to get a quite acceptable result. And we still have, despite the very modern and very good drug-coated stents, we still have problems here with distal left main stenosis, and the main problem is mainly localized in the LCX, in the circumflex artery. And in this case, we could stent again from left main to LAD with onyx stent, practically stent in stent, and pod rewiring, kissing, and then finally kissing with a drug-coated balloon for the circ. Of course, if we go to the left main stenosis, in majority of cases, we will have to treat the distal left main stenosis. And I think this is also not but to understand the anatomy. And we usually have a plaque distribution from left main to LAD, and this is a situation in around 90% of cases. Plaque distribution from left main to L6 is in around 60-70%. And of course, one more very important information, in majority of cases, we have to handle this left main diameter of around 4.0 to even 5.75. So the choice of the stand, right stand, is very important in this case. And imaging is definitely strongly recommended, and we will discuss this point maybe later on. And which technical options do we have? We have, of course, provisional side branch approach. This is a simple approach, and we will see in a few minutes the data from ABC main study. Just compared this provisional side branch approach with double stenting. And if we go to the double stenting approaches, so we have practically one setting as tap and culotte. Both approaches can be used as bail-out side branch stenting, or they can be used as a primary planar double stenting approach. And of course, we have a large data set for Dickey crush, and by definition, you always start with a side branch stenting, crushing two segment a distance of 2-3 millimeters, and following finally 11 different steps to achieve a perfect result. So this is here just showing, if you see, there are 11 steps, and there are 2-3 steps even more, according to the latest recommendation. So you see very, very complex situation. And we have Dickey crush 3 study, which is comparison of Dickey crush versus culotte stenting, published a few years back in JACC, and the result was a clear, significant benefit for Dickey crush. However, as you can see here in this slide, the difference occurred practically after first half year. So according to the probably more re-interventions. But you see, in the first 6 months, there was no really significant difference. The second large study to this topic is Dickey crush 5 study, and it was comparison for Dickey crush versus provisional side branch T-stenting, and show you just here the primary endpoint result, target lesion failure, and as you can see here in this slide, it was 11%, around 11% for provisional stenting versus 5.0 for Dickey crush approach, and this was after one year. And if you just follow subgroup analysis, so there's a majority, practically always, some trend to better results for Dickey crush as compared to provisional. And interesting was also the occurrence of stent thrombosis. I personally was really shocked because we have here really significant and a clear message from this study, definitely much higher rate for stent thrombosis in the provisional group. And this was the group which we, at least in Europe, usually prefer to use in this patient setting. So even if you perform PCI analysis for 300 patients, so the results were clear in favor for Dickey crush. Less wrist stenosis, interesting point is here the crossover to test from single to double stenting. This was a very high and around 47%. And so this was the setting in Europe. This was practically our philosophy in Europe. Try to get one stent from the main branch from the left main, usually to LAD, and then kissing with the third. So, however, in daily routine, we have a need for around 20 to 40% for double stenting. Of course, an access should be femoral, way above branches, predilatation, and especially optimal lesion preparation is really very crucial, especially if you have calcified LCX ostium, and of course always post-dilatation with non-compliant balloons following POD. ABC main study, as I mentioned, presented from our colleague David Hinnick-Smith, and the background was, so we have few randomized studies showing the results are better for single stenting in bifurcations. However, left main is a bit different kind of stenosis, large diameters, more fibrotic lesions and calcified lesions in distal left main compared to non-left main bifurcation lesions. And we have also some data showing that even two stents are maybe even, according to the survival, not beneficial. And as I mentioned, we have here different anatomical situation with distal left main stenosis, and we have our approach was provisional. However, we have now more and more data from China, from Asia, showing that Dickey crush may be the best approach to manage distal left main stenosis. And in ABC main trial, this is a European study with more than 450 randomized patients, and finally we treated 230 patients with single stenting and 237 patients with double stenting in 11 European countries, and we chosen here to use a Resolute Onyx drug-coated stent because there are few benefits for this stent. I show this in the next slide. The primary study endpoint was a composite of death MI and TLR at 1 year, and we have, of course, some few secondary endpoints. Also important point was how was the technical success rate, how was procedure duration and fluoroscopy time, etc. As I mentioned, we use it exclusively here on a Resolute Onyx stent with the option to go up to 6 millimeters. So post-dilatation is very important to avoid malapposition. So if we use Onyx, we can go up to 6 millimeters and we can avoid malapposition. Other important point is excellent access to the side branch. So we can open the side branch adequately up to maybe 4.5 millimeters. So every ostial side branch can be managed perfectly. And there is a minimal shortening, also a benefit for this stent. Technical approaches, provisional approach, step-by-step, POD, mandated, and kissing, of course, mandated. And according to the double stenting use, it was operator's choice to use TAP, culotte, or Dickey crush. And of course, here, post-dilatation, kiss, and POD also mandated. And as you can see, the patients are now going to be older and older now, patients on average more than 70 years old, and diabetes patients in around 30%. And I think also important information was we could include non-STEMI patients, patients with acute coronary syndromes in around 1/3 of patients. Syntax score around 23, and radial approach was used in 70%. 6 French shift, 60%. I personally recommend in elective case to use 7 French. So you see, of course, more stents in a double stenting group. Duration time was longer for double stenting, fluoroscopy time significantly longer for double stenting, and X-ray dose also higher in double stenting. And interesting point was how was crossover rate, and it was allowed to achieve optimal result for the patient if needed to stent the side branch in a provisional study arm. So the crossover was in around 20%. And which technical approaches were used? In majority of cases, culotte in more than 50%. Dickey crush was used only in 5%, TAP in around 30%, and I think this is also important information. If we go to the stepwise approach, usually we used TAP or culotte. Primary study endpoint, death, composite of death, MI, TLR in 14.7 versus 17.7, not significant. And if you just follow the secondary endpoints, death, MI, stent thrombus, no significant differences. However, TLR rate in stepwise provisional approach 6%, and in double stenting 9.3%. Here another graphical presentation. So finally, we missed the primary. The hypothesis was single stenting will be better. So we achieved better results with provisional by numerically lower rate, especially in revascularization. So the conclusion of this study was the stent treatment of true bifurcation left main coronary lesions with resolute onyx stent achieved good clinical results after 1 year. We had numerical case fewer serious adverse events with stepwise provisional approach. We use it less balloons, less wires. X-ray dose was lower in provisional. And finally, only 20% of patients required a second stent in the side branch, required second stent in the bifurcation lesions, in this case in side branch. And so finally, the stepwise provisional strategy should remain the approach of the choice for the majority of left main bifurcation interventions. And just one last slide, just to show you. So if we compare ABC main study with Dickey Crush 5 study, so you see we have a 22% crossover in ABC main study, around 45-47% in Dickey Crush. We usually used culotte stenting here in ABC main study, of course only Dickey Crush and Dickey Crush 5 study. And IVUS use was in both studies around 40%, similar primary endpoints, and the results were definitely here better for provisional, here better for Dickey Crush. And if we just compare these results with other data, you see we could achieve, we also in BBK2 trial, we had around 50 left mains, and we had here target lesion failure of around 7% after 1 year. So finally, I would suggest, if you have a really quite simple distal left main bifurcation lesions, from my point of view, there is definitely option and now support from randomized study to go by provisional. If you have really through distal left main bifurcation lesions with Medina 111, and if you have calcification, you could go, then you have to start with usually the Dickey Crush. For this technical approach, we have the best data, but also you can go with culotte or TAP if you're skilled in this technical approach. Thank you so much.
Yeah, thank you so much, Dr. Ferenc. I think we can go ahead with the second talk also about the bailout strategies. And the plan was to take all the Q&As at the end of the talks. If that's fine with you, we'll go ahead with your next talks.
Do you have any questions or comment? Maybe we could just discuss this point. So in our center, so we do around 3,000 PCIs in Bad Krozingen. Then this is the largest interventional center in Germany. So we still believe if we have quite standard normal distal left main, so we try still to go with provisional approach. And I will show in the next presentation in a few minutes how to perform optimal bailout stenting for the side branch. But I think there is still discrepancy in Europe between the use of Dickey Crush and culotte or TAP. So many centers in Europe, they don't like to use a lot of Dickey Crush because, I don't know, maybe by historical point, culotte and TAP came from here, and we are definitely more skilled in this approach. But I think all doctors in quite large center, high volume center, definitely, they have to know and they have to be skilled in culotte, in TAP, and Dickey Crush, definitely.
I think Dr. Swaroop has a question. We'll take the question from him first.
Thank you, Professor Ferenc, for that excellent overview of left main bifurcation PCI, different trials and review of the literature. My question is, in EBC main trial, were there any pointers which would suggest that this patient or this group of patients upfront may require 2 stent versus this group of patients may require a provisional strategy? My point is the crossover rate, though the provisional strategy was as a layered philosophy to achieve the optimal result, but the crossover rate was slightly concerning, around 22%. So would you please elaborate, were there any pointers to suggest that this group of patients would require 2 stent approach from the beginning?
Yeah, definitely. As I mentioned, according to the definition study from Dr. Chen, so what we know now, if you have subtotal side branch lesion, if the lesion is longer than 10-15 millimeters and the lesion of ostial side branch is calcified, then you usually have to perform predilatation, and then usually you have a dissection or you see there were suboptimal results, and then usually you will tend to go primary with double stenting for such kind of bifurcation, including the left main. If you have Medina 110, Medina 011, and your lesion is not really very calcified, then I would still believe in around 80% of cases you can go with a simple approach, which is provisional TAP or provisional culotte stenting. So I think in majority of cases, you can really go with provisionals. There's, as I mentioned, there's a part 10, 20% of patients with a very complex anatomy, very difficult anatomy. So then you should probably go with primarily with double stenting.
Thank you. Dr. Anacheri, Dr. Prasad Reddy.
Professor Ferenc, do you think that in the provisional strategy and this two-stent strategy, initially when this DK crush was used as the two-stent strategy, the results were, results were better. So do you think in this study, because the DK crush was not used in many patients, the Coulard technique was used in many patients, do you think that would have influenced the results in this study, or the Coulard also equally good when compared to this DK crush you mentioned?
So I showed you the DK crush study, and if you just follow the Kaplan-Meier curve, so after first 6 months there was practically no difference between both curves, and after 6 months there was a higher rate for intervention in Coulard group, and then finally after 1 year the difference was clearly significant, suggesting or showing resulting in better outcome in DK crush study on. I personally believe in all the studies we were not really so consequent using non-compliant balloons, using higher pressure to perform final kissing, using adequate POT maneuver. And if you ask me from my heart what I personally believe, and I have done more than 2,000 left-man stentings or double stenting. So I would suggest if you perform today a study and compare DK crush, Coulard, and TAP with more than drug-coated stents, and use all these needed steps with kissing with adequate size balloons, optimal POT maneuver, I personally believe there will be no significant difference after 1 year. This is my personal approach. I believe. But at the moment, we have a very clear message according to the left-man bifurcation. This left-man bifurcation reasons. The data suggests us to use DK crush. However, from Chinese perspective at least, however, now the EBC main study show us very clear there is a good way to treat our patients with provisional approach. And personally, we'll continue with this philosophy in our center. So we still pre-select the patient, very complex anatomy, okay, so maybe 10-20%, go with double stenting approach, and all other patients try to get good result with provisional approach with one stent. And I also would like to say, a few years back I presented the data during ACC meeting in the US, showing the results after 3 years, clinical data after 3 years, with more than 350 distal left-mains. And what we found in this data was a very clear message we could show if you have patients with one stent and final kissing, after 3 years, TLA rate is 10%, around 10%. And if you use double stenting, then this TLA rate increase up to 30%. So this is, I think, the current situation.
Okay, thank you.
Dr. Ferenc.
Okay, I would suggest, and I would like to share with you, I think this is from my point of view, interesting lecture, and I'm just going now to share my screen. So I hope you can see this slide.
Yes, we are able to see.
Thank you. So normally there are centers, they tell us, okay, you need double stenting for bifurcation only in 5%. Other centers, they say you need double stenting in 50%. However, we checked our more than 1,000 patients to see how is the need for side branch stenting in our center, which is really high volume center. So it's around 36%, more than 30%. And usually you will find in the literature, you will find the need for double stenting in non-left-main bifurcations of around 20%, and for left-main bifurcation lesions, is the left-main of around 40%, according to the literature. And now it's a very important point how to approach. So as we saw the data from EBC main study, in 80% of patients we can achieve really very good results with provisional approach. So you stent the main branch, make kissing, make final pot, that's it. However, in few cases, and I believe in around more than 20%, you will have either dissection in the side branch with flow limitation, or you will have residual stenosis in the ostial side branch with more than 75%, or you have TIMI flow less than 3. So this is in our center criteria, as some complex criteria to make decision, okay, we have to go ahead and to stent the side branch. And how can we do this? So we have all these options. If you stent the main branch, so we have already main branch is fine, but how to manage now the side branch? And the bailout options are TAP, which is mostly the simplest approach and mostly used approach. And we have culotte. If possible, from an anatomical point of view, there will be, of course, the angle should be below 17 degrees, and the diameter between side branch and the main branch should be not more than 1 millimeter. So if you have here 4.0 and 2.5, and this will be suboptimal anatomy for culotte. And finally, you can also stent the main branch as provisional, and you could also go here with the reversed mini crush. So you can stent the side branch, make some protrusion here of around 2-3 millimeters, and then crush, pot, kissing, and final pot. And now take a look how to manage the problems with the TAP. And if you stent the main branch or proximal LAD and you have large diagonal branch, whatever, so you have two big topics. First of all, you can miss the ostium completely, and you have a gap here, and so you have to correct this. And other problem is you have too huge protrusion from the side branch. It could be, let's say, from LCX to the main branch, and too many struts are protruded into the main branch. So this is the second big problem. And we just check now how to manage the gap. So there are practically two options. Either you take again a very short, usually 8 millimeters stand, and try to catch here perfect ostium. And you have always tried to, or your orientation point will be upper point of the carina. So you have to do here to perform a kissing and final pot maneuver. And kissing will be important to do with NC balloons. So finally, you can manage this with 2 stands. So gap, 1 stand more, kissing, so you have still here some metal burden in the carina region, but if you do finally kissing with non-compliant balloons, if you go with 14, 16 atmosphere, so then I think you will achieve definitely very nice result, followed by final pot. Other option is to go in such cases to take larger stand, again quite short, probably 8 or 12 millimeters, probably 8 millimeters, and practically to convert to culotte stenting. And I have done such cases because there was a mismatch here and some gap, and then I decided to take shorter, larger stand and to convert to culotte. So you stand, make a pot, rewire very distal to the carina, make kissing with non-compliant balloons, make finally final pot. So you can manage this by a second stand, and so you have here practically optimal pot with second short stand, or you prolong to the main branch and do kissing final pot, so you have here optimal pull-up. This is a very good option to manage this problem with the gap. If you have large protrusion, so you can usually convert, and this is the simplest way to manage this. You just go with a balloon adequately sized according to the proximal side main branch diameter. You crush the struts, cross with rewiring, and perform kissing and final pot. So you have a mini crush option. So this is good option to manage such large protrusion. Please don't let something like this, because you have too many struts floating into the main branch, and this could be associated with a higher risk for stent thrombosis. So this is definitely a safer and better approach. So you can manage this with kind of reverse mini flush. And what I would definitely recommend to you to use imaging OCT or IRIS, if possible, if applicable, so you can really check the ostium of LAD, LCAs, whatever, and finally proximal left. So you should know, we should be sure there is no sizing problems, there is no malapposition, there are no H dissections. So this is just showing here a case from our so how to do this in daily routine. So if you have here, let's say, left main, so you predilate the lesion, you have wiring in the side branch, go with the stand, implant the stand, make a pot, then rewire, and rewiring should be very distant to the carina. You can usually go then with balloons to do kissing, and if you have up to kissing final results, it's good. Okay, you have no dissection, you have two-leaf flow, and your residual stenosis is below 75, you can let it. Or you can go with FFR wire and test the flow of FFR. And If you have, let's say, suboptimal result, maybe dissection, whatever, you usually go with one stent more. This stent is usually smaller, maybe 2.5, 2.75, 3.0, whatever. And now, very crucial is the positioning of this side branch stent. If you implant the stent in this position, you could achieve here some kind of edge of gap. If you implant the stent in this position, this will be really suboptimal, because then you will have here large protrusion. And what is really very important to go forward, so you need some kind of protrusion, but this protrusion should be around 0.5 millimeter. And please always check the position of the side branch in 2 or 3 different projections. I think this is also a very important point. So we usually are doing this simultaneously with balloon in the main branch. So we start with the side branch implantation, 2 atmospheres, balloon 2, 4, 4, 8, 8, 10, 10, 14, 14, and finally, this should be now shown. So we have now optimal position and can now start the next step with implantation of the stent. So then we can be quite sure we have here complete coverage of the ostium. What I usually do is just go back with balloons from the side branch and make again fine kissing. So like this, and this is usually working very nicely. What you can do is to repeat this approach using non-compliant balloons. I think this is also an important point, and definitely final part. So you are able to perform practically a dedicated stent. You use 2 stents, and finally you have one construction looking like this. You can also do IVUS, like in this bench test in the cath lab, and if needed, you just can go with again with post-dilatation, with larger balloons, and of course pod. And so you achieve a construction like this. So from 2 stents you make very nice double stenting construction. Culottes, what is really very difficult in culotte, you usually go, there are 2 options. You usually go to the more angulated, you usually stand to the more angulated branch, which is usually side branch, but you can go here straight on, and if needed, you can go through the struts, again crossing to the close to the carina, and do kissing and go with a stand, pot, rewiring pot. That's it. What is sometimes the case that there is a problem with a diameter mismatch. So you can, I have done such cases, just take smaller, adequately sized stent in the side branch, and in the next step you can take a larger stent from the side branch to the main branch, because if you go practically initially with large stent, you could make a dissection or even perforation. If you have a stent inside, I never saw any problems with this approach. So this is also working very nicely. If needed, you do just kissing and provisional approach, you see how it looks, and if needed, you go with 1 stent more. So practically you can go on them with optimal. Okay. This will result in optimal culotte approach. So a mini crush or reverse mini crush, if you stent the main branch and there is only option to go with the stent, to crush the 2-3 millimeters, rewire to kiss and to perform time kissing. This is also optimal. So by reverse mini crush, there are sometimes problems with crossing, usually crossing with the wire, crossing with the balloons. So what is usually helpful to have to choose optimal guiding catheter, to have good backup. Sometimes you need guiding extensions. Extra support wires are very important. Low profile balloons should be available in all cath labs. Report is very useful, and sometimes if you do report, you make the struts a bit repositioning of the struts, help to cross again, and if needed, you can use such dual lumen microcatheters, or you can use such angulated microcatheters. So I use such angulated microcatheters usually once a month or twice a month to check to be successful in bifurcation crossing. So this is just to show for younger doctors how to perform culotte. Then we can discuss next presentations. So you stand from the main branch to the side branch or on the main branch. What is really important to perform pot. For recrossing, then recrossing will be much easier. Recrossing is here usually needed to be here very close to the carina. And before you remove the gel wire, I first cross with the balloon, and then I remove the gel wire just to have better support. Usually, I recommend to take new 2.0, 2.5 balloon, and the crossing is usually fine. You open the struts to the distal side main branch. You can do this with one balloon, or you can do this as a kissing bundle. And this approach will result in double kissing culotte, which we now recommend to use. So you not just open with one balloon, you make a kissing, first kissing, then the next step is clear. You just cross with the main branch or larger stand. Before you implant the stand, remove the wire from the side branch, and you should cover the stand with 1 or 2 millimeters. So you just here only to show you how useful is this proximal pot maneuver. So your choice will be this the side main branch diameter 3.0, let's say. Here you have 3.5, maybe even more. Just go with short balloon, step here at carina level, and then there is no malapposition anymore. Crossing is simple, and final pot should be done. So this is really very, very useful. So if you go here with all the steps, final kissing, this is the second kissing, and this is a perfect culotte result, so 100% complete coverage of the side branch ostium. And if you just check this proximal part, because I was initially a bit skeptic how it looks here inside the stand. If you do OCT, you see there is a only 0.1 millimeter double layer of slats. Thank you so much, and now I think open for discussion, and would like to see your cases from you, Katman.
Thank you so much for those wonderful presentations. I'm sure the entire audience, they might have learnt a lot. One of the problems, actually a complication which we once faced was after we put the side branch stent, we were not able to pull back the stent into the main vessel because of the strut interaction. So the side branch stent, the angle was slightly more. went ahead, we wanted to go ahead with the TAP strategy, and then the stent was not coming back into the main vessel. Just wanted to know your thoughts on that. What do you do in those situations? Just deploy the stent there and then take another stent and try to do a tap, or any other ideas you have, or anytime you face that type of a peculiar situation?
I couldn't follow you because the quality of voice was not good. It was a question or comment. I'm sorry.
Okay. Actually, we went with a provisional strategy after the main branch stenting. We did the pot and kissing balloon. Then there was a dissection in the side branch, so we thought we'll put the side branch stent. We wanted to do it with the TAP strategy. So we went with the stent into the side branch, and while we were pulling back, it was not coming back into the main branch. The strut was hitting the main branch stent, and whatever we did, the stent was tending to embolize over the balloon rather than coming back into the main branch. So just wanted to find out if anytime you face such a peculiar situation, and what would your strategy be in this particular situation? Would you just deploy the side branch stent wherever it was and then take another stent to cover the ostium, or anything else you would think of? I'm not sure if I was clear.
The topic I recross in the side branch is so we usually are to not we don't use adequate sized balloon for pot. This is one problem in many cases. I think we usually choose too small pot balloon, and I usually do report if I have problems with the crossing. This is point number one. Other point is if you cross with the wire and there is still a problem to cross with the small balloons, then I would again try to get wire with extra support qualities, and to get some different struts to cross different area of struts. If there is still a problem, then I would try, if available, I would try to get imaging to see how it looks, or even to postulate complete all stented segment, and again pot, and again rewiring. So this is only the question of time and availability of good wires. And if there is still a problem, you could use double lumen microcatheter. If you sometimes have to cross from large main branch to the quite small and undulated side branch, very helpful tool is to use undulated microcatheters. So they are different undulations, 90 degree and 120, and this is extremely helpful in some critical situations. So, and then I usually go with 1.0, 1.5 new balloon, then 2.0, 2.5, 2.5 non-compliant, then choose the next choice will be adequate size large non-compliant balloons to perform kissing.
Yeah, thanks so much, Professor Ferenc. I think we'll go on to the first case. Dr. Uday is my colleague cardiologist, and he'll be just presenting to us a case of left main bifurcation using the provisional strategy. Over to you, Uday.
Good evening, everyone. So today I'll be presenting a case, left main stenting provisional strategy. I'll be going through the steps of a provisional strategy with a simple case example. So the idea of this talk is to mainly show how to optimize the results in a provisional strategy and to understand the rationale between each step. So we'll start away. So it's a 63-year-old male, known hypertensive. He had a history of coronary artery disease, underwent angioplasty 15 years back. He recently had COVID. He presented with anterior wall ST elevation MI to a outside center where he was thrombolized in view of COVID. And he was then discharged home on medications. He came back to us after a month with angina on exertion. So we did the, this was the presenting ECG to us, which showed revolved anterior wall MI with T inversions. And the echo was showing RWMA, regional wall motion abnormality in the distal IVS apex with mild LV dysfunction. EF was around 48% and rest was normal. So this was the angiogram. The right coronary artery showed mild disease in the mid RCA, but overall it was okay. So this is the left-sided injection. So the PA caudal view showed there is a stent in the ostial LAD with a critical narrowing in the osteoproximal LAD segment. Rest of the LAD was fine. And here you can see the left main, distal left main and ostial LCX were mildly diseased. So how do you proceed with this case? So it is a coronary artery disease, single vessel disease, osteoproximal LAD involvement. So we calculated the syntax 1 and syntax 2 scores. So it was coming to around 10, and which showed that the 5-year MACE rate and 10-year mortality were slightly higher with CABG. So we decided to go ahead with the percutaneous intervention. So in the strategy, how do we deal with the left main bifurcation? This is a non-true left main bifurcation. As you can see, the ostial LAD is critically diseased and distal LM and LCX osteum are having only mild disease. So here, as per the algorithm, our side branch lesion was less than 70%. And the lesion length was also less than 10 mm. It's a simple lesion and a big side branch with a favorable angle with easy access. So provisional strategy was preferred. So then the question was whether to do an ostial stenting again, because the previous ostial stenting he did well for 15 years, versus a crossover. Ours is a Medina 010. We choose a crossover technique because if any complication we might end up putting another stent with overlap, especially in the distal left main. So this was the plan which we thought before going in. Wire both the branches, single stent, crossover from left main to LAD, and it is sized according to the distal main vessel, and then do a pot. Once pot is done, then we would cross the side branch through the distal strut with another guide wire and then remove the jail guide wire. Then in view of distal left main, if there is any compromise, go ahead with kissing balloon inflation, then do a repot and see the result. This was the plan before we went ahead with the case. So we will discuss why each step was planned like this and what was the result. And did we have to change the plan also, we will discuss. So first LAD was wired with a BMW guide wire. Then even LCX was wired with another BMW guide wire. So both the main branch and side branch were secured. Then pre-dilatation was done sequentially with the 2x12, 2.5x12 non-compliant balloons. We didn't pre-dilate the side branch, only the main branch was pre-dilated. Then we went ahead with stenting, 3.5x38 resolute tonics. First we positioned, saw the distal positioning in a cranial view, then positioned the proximal part in a caudal view. Once we were happy with the position and there was adequate stent in the proximal main branch, which is very important for pot technique. At least see that 8 mm of the stent is in the proximal main branch. Then we deployed the stent and check angiogram.
Sarah, did you perform pre-dilatation of ostium LAD?
Yes, sir. We did pre-dilatation of ostial LAD with a 3 balloon. So once, So stent is deployed, then we optimize the distal main vessel stent with the help of a 3.5 into 12 balloon. Then pot was done. This was done with a 4 into 8 mm non-compliant balloon, and the most important step here is to position it just before the carina. Why pot is done, why it is so important to do a pot is, the stent is always sized according to the distal main vessel. So there is a malopposition, whenever you see there is a malopposition in the proximal main vessel. So if you size the stent according to the proximal main vessel, then it can cause carinal shift and compromise the side branch. So pot is done mainly for two things: to proper apposition of the stent in the proximal main branch and good side branch, good scaffolding of the stent around the side branch, so it will be easier to the wire to recross. So once pot is done, then the second step is recrossing the side branch. One important point at this thing, we should not remove the jailed wire before pot, because there will be a gap in between the main vessel stent and the main vessel wall, and the recrossing wire can always go in between the stent and the vessel wall, which can later lead to distortion of the stent if we inadvertently pass a balloon and dilate. So after pot, once we recross through the distal strut, then only we have to remove the jailed guide wire, because suppose in case after we do a pot and there is compromise of the side branch, the jailed wire will act as a marker of where we have to search for the side branch ostium, and sometimes when we are unable to rewire it and patient is having symptoms, then we can use a jailed wire payload technique by passing a small 1 or 1.25 mm balloon and underneath the stent struts and re-establishing the blood flow. So recrossing should be done through the distal strut, and then only the jailed guide wire has to be removed. So why to recross through the distal stent strut? Once you recross through the distal stent strut, it creates a better scaffold. Here you can see the stent struts are opposed to the wall better, rather than when proximal crossing and side branch optimization is done, then the stent struts will be protruding if proximal crossing is done. So we should do a distal crossing. And while removing the jailed guide wire, we should be very careful, because guide is pulled inside and it can cause guide induced dissections, and sometimes it can lead to proximal stent distortion, longitudinal distortion also. So if we have any difficulty, we might always advance a microcatheter over the jailed guide wire and then slowly pull it out. So in this case, we successfully pulled out the jailed guide wire, and now we opened the side branch struts initially with a small 2 into 12 balloon. Then once it was optimized, then we went ahead with a kissing balloon inflation. So kissing balloon inflation is one very important step here. Non-left main bifurcation, yes, we think about whether it is needed or not, but here both the vessels are huge. Each of them was around 3.5 mm in diameter, so we chose to go ahead with kissing balloon inflation. So we positioned a 3.5 into 12 mm balloon in LCX, and first we inflated the side branch balloon so that the stents, the metal is shifted towards the main vessel. Then we sequentially inflated the main branch balloon to 8 atmospheres, then went ahead to 12 atmospheres with both, and waited for 10 to 20 seconds, because it's a left main, we cannot hold more than that, and then simultaneous deflation. So the idea of doing a kissing balloon inflation is mainly to put the neocarina or flow divider exactly in the center, so that the shear stress is equally distributed, and also the side branch is optimized well. Otherwise, once wherever the shear stress is low, it may lead to a development of an ISR. So once kissing balloon inflation is done, then we went ahead with the final pot, because the proximal stent will be deformed. So here again, precise balloon position is very crucial to avoid crushing of the neocarina. So we took a 4.5 into 8 mm balloon and did the final pot. So this was the final result. Summary takeaway point from this case is, provisional stenting is the preferred strategy for bifurcation lesions without compromising long-term outcomes. Sometimes 20% of the times we might require to go ahead depending upon the anatomy of complex bifurcation lesions. And wherever possible, if we take the help of FFR and imaging like IVUS and OCT, the crossover rate from provisional to two-stent has now come down to single digit. And after FKBA, report is advised to prevent proximal distortion of the stent. And operator, whoever is trying to do a provisional strategy, should be thorough with at least one of the bailout strategies, and TAP is the most preferred strategy. Thank you.
Yeah, thank you, Uday, for that elegant presentation. I think we'll take comments from Professor Ferenc, and then we'll go on to the next case. Over to you, sir.
Yeah, very congratulations to this case. It was perfectly done, step-by-step provisional approach. Every step was perfectly placed. And what I personally believe was the stent choice. So you use it onyx stent, which is some advantages in this case. You can make post-dilatation in the left main up to 5.5. This is one point. The shortening is minimal, but you try to avoid some shortening, taking care to the optimal position of the guiding catheter. I think this is important point. What I do in our daily routine, if you have, after stenting you usually go according to the plaque distribution from left main to LAD. If you perform stenting, you make safety check, everything is fine, flow is okay, you remove balloon, and the flow to the circ is very good. Then I usually go with a balloon to the main branch and to the proximal part of the stent. And I think you mentioned how important is to, if you don't cover complete left main, how important to have at least a segment or area of 6 millimeters which should be in the left main. Only then you can perform adequate POC maneuver. And if the POC maneuver is done, the crossing to the main branch in this case, to the side branch in this case, to L6 is quite easy. What you nicely showed in this case report was the wiring. You went with knuckle approach from LAD, very gently, step by step to the L6 also, and then you can be quite sure you cross really very, very distally, and that's, as you showed in one of the slides. It makes nice scaffolding to the side branch. This is exactly perfect done case. And what I would like to mention, you use it 1 or 2 times clear stent function, a stent boost option, and this is really very nicely shown how it looks, how struts are. They are perfectly open, and there is some suboptimal area which maybe need one more post-dilatation. So I usually use also in daily routine clear stent functional stent boost for such perfect balloon positioning maneuvers. So very nice, perfect done case, perfect result. And you have also, with the choice of onyx stent, you have also option to go with a shorter duct, because there is also data according to this point. You could even, there is a bleeding option, whatever bleeding risk, high bleeding risk, so you could go with short duct duration ahead. Okay, I would thank you. So that's really perfect case, and I hope now you show a case with double stenting.
Yeah, Professor Ferenc, there is one more question from the audience. They want to know if all your cases of left main you would do side branch dilatation, or are there any situations where if you have got a perfect result with just the crossover stent, you would do the pots and just remove the wires and come out without dilating the circumflex? Dr. Ferenc, are you able to hear us? Were you able to hear us? Dr. Ferenc, were you able to hear us?
I didn't follow you because the voice is here it's not clear to her. Do you have one more presentation with
Yeah, we'll go ahead with the
double
next
stenting?
presentation.
So good evening all. After the provisional strategy for the left main bifurcation PCI, now we'll discuss and present a case of two stent approach, where upfront we chose the two stent approach, and the operating team is was Dr. Prasad Reddy and myself. So clinical history in brief is a 60-year-old gentleman. He's a diabetic, hypertensive, and hyperlipidemic. So he presented with functional class 3 angina with crescendo symptoms and significant worsening, and a couple of episodes of rest angina and the postprandial angina since last 10 days. So it was he was a morbidly obese with the body mass index of 40, history of he's having obstructive sleep apnea and a history of prior colonic surgery for the colonic diverticulum. He was not in heart failure, he was in class 1, troponin was mildly elevated, and ECG showed Q waves in inferior leads with echo showing no regional wall motion abnormality and normal LV function. So basically it is a non-STEMI presentation in a morbidly obese gentleman with a prior history of colonic surgery. So ECG, as you said, as you see, there are Q waves in the inferior leads and no other significant changes. So this is his diagnostic coronary angiogram, which was performed as an early invasive strategy, where you clearly see there is a critical distal left main disease extending into ostial LAD and ostial LCX, and additionally there is a critical lesion in the big size OM, and RCA was subtotally occluded, and probably this is related to, this is a ACS related vessel. So though upfront on angio, while we are doing angiogram, patient was very keen for ad hoc procedure. But considering this complex anatomy, we preferred the heart team discussion, and his syntax score was 27. We had a detailed heart team approach and the discussion. Surgical team consultation was sought, and we didn't go for the ad hoc procedure. Surgical team's concern were morbid obesity and the obstructive sleep apnea, but still CABG was offered, but patient categorically declined the CABGs after complete understanding. Hence, he was planned for PCI with the aim of complete revascularization, as we are aware that the residual syntax score, which is more than 8, is associated with the adverse outcomes. So goal here was to have a complete revascularization. So its syntax 2020 score is 10 years mortality with PCI is 0.6% higher than the CABGs, and 5-year MACE rate with the PCI are 0.7% higher than CABGs in his syntax score 1, which was 27. So with that we proceeded, and since we thought RCA is a ACS related vessel and it's a subtotally occluded vessel, so we could finish the RCA PCI with 2 regulating stents in overlapping fashion with reasonably good result, though there was a loss of small side branch, RV branch, but patient was clinically stable. So then we decided to proceed with the left main bifurcation lesion. We did this in a same index procedure because of the morbidly obese patient, and RCA was relatively straightforward. His creatinine was normal, and there was not significant contrast used during the RCA, and hemodynamically and otherwise patient was stable with the normal LV function. So as you see, there is a critical left main bifurcation lesion extending into the ostial LAD and the ostial LCX, and then the OM, which is a fair size OM, has an additional critical 80 to 90% lesion. So it's a true left main bifurcation lesion with Medina 111. So always still it's worthwhile going through that treatment algorithm of bifurcation PCI. Is the bifurcation true bifurcation? Yes. And then is the side branch suitable for stenting? Yes. Again, does the disease in the side branch extend more than 3 to 5 millimeter from the ostium? Again, yes. So elective 2 stent implantation was a reasonable approach we thought we should have here. So we chose a DK crush technique because of the true bifurcation lesion requiring elective double stenting in our opinion. And there is a emerging favorable evidence in a left main bifurcation PCI. Just now we discussed that, and the DK crush 5 especially clearly showed a favorable outcomes with the DK crush technique. And the most important deciding factor was our familiarity with the DK crush technique. So that's why we chose the DK crush technique. So just in brief, advantage and disadvantage of the crush technique, because all of us know that crush technique has evolved significantly over the period of time from classic crush to mini crush to the DK crush. So advantage is assures side branch ostial coverage with the stent. Access to the either branch is never lost and can be used even in significant mismatch in the main vessel and the side branch vessel diameters. Even it is a technique which can be used in clinical instability and the complex anatomy. And we have usually there is a good long-term outcome and the long-term data with the crush technique or the mini crush or the DK crush. Disadvantage is difficulty in recrossing side branch through multiple layers of stent. But with the advent of DK crush, probably the final kissing balloon inflation has become predictable. And initially with the classic crush, almost 10 to 20% of the cases, it was difficult to perform a good final kissing balloon inflation. But with the DK crush, now you have to literally cross a single layer of metal and you can easily recross. But flip side is difficult to treat side branch restenosis, which is the Achilles heel of any bifurcation PCI. And it's not so optimal technique for the wide angle between main branch and the side wall. Not that it cannot be done, but it is mainly preferred for the narrow angle between the main branch and the side branch. And yes, DK crush, it's a complex technique. It has its own learning curve. It's time consuming and you have to perform it in a stepwise fashion. So just quickly, we'll go through the procedural details. So you both wire main vessels, main branch and the side branch. You predilate main branch and side branch as per the lesion morphology. Position and deploy the main branch stent, and then you perform the first balloon crush once you remove the wire and the balloon from the side branch. Then rewire preferably through the proximal cell. And majority of the bifurcation techniques you cross through the distal cell, but in a crush technique or the DK crush you should cross through the proximal or the middle cell. Then you perform the first kissing balloon inflation. Then you perform the deploy the second stent in the main branch. Then you do the pod. Then again rewire the side branch again through the proximal or the middle cell. Perform a second final kissing balloon inflation, and then you do a repod. So typically these are the 7 main steps of the DK crush, but they can be subsequently modified as well. So after wiring both the branches and predilating the LCX and the LAD, we did the side branch stenting first with the 2 millimeter protrusion of the side branch stent into the main branch, and balloon was kept in the main branch, that is in left main. And then with the same stent balloon, we came back into the left main and we gave a high pressure inflation to expand the ostium of the LCX adequately. Then once the result in the LCX were good and LCS was further optimized, we did the balloon crush, first balloon crush, but here we did the 2-step balloon crush. So first balloon crush was matched to the LAD size, that is 3.5, and second balloon crush to crush the portion of the stent which is protruding into the left main with the 4 millimeter non-compliant balloon. So this is again important to have a good crush of the side branch stent and have a good side branch ostial expansion to facilitate the further steps. So then with the workhorse wire itself, that is BMW, we could cross easily with probably, I would say less than in a 1 minute, we could recross, and we didn't have to use any special wire or any special technique, and we ensured that we are through the proximal or the middle sail. And then we did the first kissing balloon inflation with the 3 millimeter balloon in the LCX and the 3.5 millimeter balloon in the LAD. So this was the first kissing balloon inflation. So after the first kissing balloon inflation, patient complained of severe chest pain, and there was significant left main dissection, and the flow in the LAD is completely reduced, but the flow in the LCX is good. So this is one of the advantage of the crush technique, where DK crush is in the crush technique, where the side branch is secured and the main branch access is never lost. So what all we had to do was quickly secure the main branch, and this is one of the advantage of the crush technique when things go wrong, because you never lose the access to the main branch. And we quickly deployed a 3.5 into 38 onyx stent from left main to LAD covering the ostium, and we could quickly stabilize the patient, and situation didn't worsen, and patient remained hemodynamically stable. Once the patient was hemodynamically stable, then we performed the POTS with the 4.5 non-compliant balloon. We ensured that the POT balloon is up to the carina to have a good opening of the main branch stent toward the side branch. Then again we recrossed to the proximal or the middle sail, and we performed the second kissing balloon inflation. Here first we did the sequential inflation, meaning is first we inflated the ostium of the LCX with the 3 non-compliant balloon high pressure around 20-22 atmospheres. Then with the 3.5 non-compliant balloon in the LAD with around 20-22 atmospheres, and then final kissing and inflation with the inflation of the LCX balloon first, then the LAD balloon, both at 12 atmospheres, and we deflated simultaneously. Then we performed the report with the 4.5 non-compliant balloon, and then we were reasonably happy with the expansion of the stent, well expanded stent in the left main, reasonably well expanded stent in the LAD and the LCX, and good TIMI3 flow distally, and all the small side branches also were well preserved. So we did the final IVUS run, which showed a reasonable area of the stent, MSA of 7.5 millimeter square in LAD LCX, and then 7.7 millimeter square in LAD, and 15 or close to 16 millimeter square in the left main. So we were happy with the result. So just quickly summarize the procedural steps. We did pre-dilatation of the LCX and the LAD, stent deployed in LCX with 2 millimeter protrusion into LMCA with 2.75 into 48 millimeter stent. Then optimization of the LCX stent is again important, which we did with 3.5 non-compliant balloon, and we did high pressure ostial expansion with around 20-22 atmosphere. Then we did 2-step balloon crush of LCX stent with 3.5 and 4 non-compliant balloon respectively. Then we ensured that we recrossed to the proximal cell, and we did first kissing balloon inflation with 3 non-compliant balloon in LCX and 3.5 non-compliant balloon in LAD. Then we had to do LMCA to LAD main branch stenting in an emergency fashion, which we did with 3.5 into 38 stent. Then we did distal optimization of the LAD stent with 3.5 non-compliant balloon with the high pressure at around 20 atmospheres, and POTS with 4.5 non-compliant balloon. Then again we recrossed to the proximal or probably the middle strut, and then we did final kissing balloon inflation with 3.5 non-compliant balloon in LAD and 3 millimeter non-compliant balloon in LCX. We did report with 4.5 non-compliant balloon, and we did the final IVUS run. So why it is important, just one slide about why we should cross proximally and not distally, because always your side branch stent is tilted towards the main branch away from the carina, and if you cross distally, probably there is a chance that you may go below the stent, and then your wire may go below the stent, and then further you can distort the stent during final kissing inflation, and then there will be incomplete scaffolding of the side branch. So preferably you should cross to proximal or the middle cell. How to optimize DK crush technique by Professor Shen, the high pressure ostial LCL dilation, because invariably that will be the reason for the side branch failure, or that is the Achilles heel for any bifurcation PCI, left main bifurcation, or any bifurcation PCI with two-stent approach. Optimization of the side branch stent is again very important. Many times it's overlooked, and the proper crush of the side branch stent in the proximal bed branch, that is in a left main with appropriate size balloon, is important to have smooth recrossing and predictable final kissing inflation. To conclude, ladies and gentlemen, DK crush can be a preferred strategy for elective double stenting or two stent approach. At present, there is no conclusive evidence to say one technique is superior to another technique. We should be familiar with the different techniques, but we should master one technique. And always the technique which you have mastered is going to give you good result than and then always be mindful of the local results. It's very tempting to extrapolate trial results and then to apply into your daily practice. But local expertise, local experience has to be taken into consideration before adapting to any complex strategy. Step-by-step approach is key for the success. But remember, the technique which is simpler, safer, and effective is going to stay longer. Make everything as simple as possible, but not simple. Thank you.
Yeah, thank you, Dr. Swaroop. I think that was a wonderful demonstration of two-stent technique. I'll hand over to Professor Ferenc for his comments, please. Over to you, sir.
So from my point of view, again, good case pre-selection. So it was definitely a very complex distal left anatomy. So Medina 111. The bifurcation angle to the L6 was very difficult to approach, and I think, as you mentioned before during your presentation, it was really very important and crucial point to have permanently the wire in the main branch, which was LAD. And this was very helpful to manage this case by stenting, as you had you had some troubles and no flow or slow flow in LAD. So it was a really crucial point then just to go straight ahead with a stent from left main to LAD, and then you rescue the situation. So I would always recommend you, if you have really such a very difficult anatomy, to choose a technical approach where you have safe the wire in position in the main branch usually, because main branch is probably mostly larger area to cover, and in this case it was really life-saving decision for this patient. Even to go to start with the right coronary artery, which was quite simple lesion, then you had more safety to go to approach with this complex distal left main stenosis. What I would like also to mention in this case is to make final IVUS evaluation to see how it looks in LAD, how it looks in L6, how it looks in left main. I think very clever and very good decision to be sure your result is really perfect for this diabetic patient. Diabetic patient. So I think we should try always to achieve a perfect result, like in this case. So from my point, really congratulations, a perfect done case.
Thank you so much, Dr. Ferenc. I think we are almost nearing the conclusion of this session. I would like to just summarize before we close. I'm sure at least myself, I have learned quite a lot in the last 1.5 hours. At least how to approach a bifurcation lesion, when to decide a two-stent versus a provisional strategy, the overall concept of the philosophy of provisional strategy, where we know when to go ahead with a bailout strategy, and very elegantly, as you demonstrated, which strategy to use when we are using two-stent strategy and which strategy to use when we use a bailout strategy. And probably as Uday and Swaroop finally mentioned, it's important that we are aware of all strategies, but at least master one to make sure that we and our patients come out safely from the cath lab. I would again like to thank you for sparing your valuable time. All of us know how busy you are, and then trying to take your time out to spend with us, and definitely sharing your knowledge. I'm sure tomorrow when we walk into our cath lab and try to handle a bifurcation, thanks to you, we'll be able to do a better job than what we did today or yesterday. Thanks once again, and with those comments, as I think we have ran out of time, we'll close the session for today, and thanks everyone for your questions, comments, and actively taking part in this session. Thank you.
Okay, thank you so much. Bye-bye.
Bye.
Thank you. Bye-bye. See you soon.
Thank you so much.